Thank y'all. I'm going to talk a little bit about spine surgery and some of the perioperative emergencies. In other words, what can go wrong either during surgery or after surgery that we're going to need to deal with. And for those of you that know me and I work with every day, I just want you to know that all day long, the question I've been asked is, who died? Because they figure if I'm in a suit, either somebody died or I'm preaching. So I'm preaching. Do we have a remote? Is this it? Oh, it is. Okay. This is too loud. I'll speak loud. Yeah, turn it down because I'm going to be making a lot of noise here. When we're talking about spine surgery, it's pretty simple. We divide spine surgery into three basic areas. If we're going to operate on your spine, we're going to operate either on the cervical spine, the neck area, the thoracic spine, or the lumbar spine, which is the low back. And each of these areas have somewhat unique problems that can arise in the perioperative period, as well as different types of emergencies that might show up after we do a surgery. Some of them, however, some of the problems we encounter, we can see in any area of the spine, whether it's cervical, thoracic, or lumbar. But in order to understand these emergencies and how we have to deal with them and what causes them, we really need to understand what we're doing during the surgery. What are the mechanisms of the surgery, and that will allow us to better treat the potential problems that arise. So let's talk a little bit about the cervical spine. Obviously, the most common procedure that we do in the cervical spine is an anterior cervical discectomy with fusion instrumentation. That means we're taking a disc out of the neck and we're putting a piece of bone or something like bone in there to replace the disc we removed. And then we're putting a titanium plate on the front of the vertebra to basically hold everything in place. Typically, we're doing this operation for a herniated disc. Hello, doctor. How are you? No, I'm talking, Dr. Handy. Typically, we do this for a cervical disc herniation, and we can do this at one disc. We can do it at multiple discs, but this is generally why we're doing surgery. It's for some type of degenerative process, such as a herniated disc. Now, we can do this for trauma. We can do it for instability or deformity that we see in the cervical spine, for infection, for tumors, but on the whole, we're generally doing it for some type of degenerative process. This is an example that we can see here. This patient has some pretty significant degenerative changes, has some compression or pressure on the spinal cord. That's the type of patient that may get an anterior cervical fusion. You can see this in multiple levels. You can see some additional problems. Sometimes we see ossification of ligaments or calcification of ligaments in the spine. But these are typically the types of problems that may lead to someone having an anterior cervical surgery. The most common approach to the anterior spine is to what we call a retropharyngeal approach. Okay, as a surgeon, a right-handed surgeon, I typically will do this surgery from the right side of the neck, not depending on where the pain is. It doesn't matter if the pain's on the left or right. I'm going to do it from the right. I'm more comfortable with that. Some surgeons, particularly orthopedic surgeons, but a lot of patients will get an incision on the left side. It doesn't matter. So if the patient comes in and says, something's wrong, my left arm was hurting, he cut me on the right side, we haven't done anything wrong. And believe it or not, despite the fact that we tell them this pre-op, patients will sometimes say that after surgery. What we do, though, is we will go in and we will mobilize both the midline structures, the trachea, the esophagus, and we'll move those medially. And then we'll also mobilize the carotid sheath and pull it laterally. And that really doesn't matter which side you're going from. That's what's going to happen during the surgery. Just this exposure by itself is actually the source of some of the major perioperative complications that we see. And we're going to talk about that just a little bit. Okay? Just to give you a frame of reference, this is an intraoperative photo. Obviously, the surgery is completed. We're closing the neck. but this is going to be the frame of reference for all of the pictures we're going to see. The head is up here. This is the right side of the neck. The chest is down here. This is where we typically will make the incision, drain tube left in, but keep that reference frame in mind as we move along. This is what we actually do during the surgery. If you look here, we've got the trachea and the esophagus are pulled over here behind this retractor blade. The jugular vein, carotid artery, vagus nerve, basically all the things in the carotid sheath are pulled over here. And this was the disc. The disc is now removed, and at the bottom of this, we'll see the dura, which is the covering over the spinal cord. Okay? Once we decompress whatever we need to decompress or remove the disc, we then will put a piece of bone into the disc space that's going to act as a spacer, and ultimately, we hope, will fuse with these adjacent vertebrae. And in general, it does. We generally see a very high fusion rate with a single level disc. Then we put a plate in. That plate is going to stabilize the procedure. Is going to stabilize this disc internally. Obviously, it will at least, in most cases, prevent propulsion or expulsion of the disc anteriorly. And then that is screwed to the vertebra with screws. These are screws that go into the cancellous portion of the bone. And since they sponsor us, this is a Stryker plate. And this is what Scott, the short guy back there, sells. This is what it looks like on X-rays. This is a single level cervical fusion, and this is a multi-level cervical fusion. And this is not immediately post-op. You can see that's actually fused together. Okay. So let's talk about some of the things that happens as a result of me messing in people's necks. One of the things that we frequently, or I'm sorry, not frequently, but we can see is a recurrent laryngeal nerve injury. Okay, and the laryngeal nerve is located in the tracheoesophageal groove, and during retraction, it can be injured. And in some patients, particularly on the right side, it runs a little bit of anomalous course. It runs a little higher than it does on the left side. In general, and there's a lot of controversy about this, but it's felt that you can get a nerve injury as a result of improperly retracting tissues or putting your retractors in the wrong place. Now, I'll tell you, you can get it even if you do an absolutely perfect job. But what happens is if you have a laryngeal nerve injury, the vocal cord on that side doesn't move anymore. That's the nerve that innervates the vocal cord. Okay? Now, most of the time, this is a temporary issue. It will resolve over a short period of time, but it can be significantly disabling for the patient. Now, generally, what you're going to see is the patient's going to be hoarse. They're going to have a raspy, low voice, and you're going to know this immediately after surgery. Now, the other problem, and the reason this can be a nursing issue, is that these patients can be prone to aspiration, so you've got to be careful and watch out for that. If these do not resolve over time, sometimes we actually have to do an ENT procedure or have our ENT colleagues do a procedure that will fix the vocal cord. Now, the thing you have to be aware of is that you have to be very careful if a patient has had a vocal cord problem or a recurrent laryngeal nerve problem in the past, and you don't ever want to go on the other side of the neck, because if they have a bilateral recurrent laryngeal injury, these patients, they're going to lose their airways. They're going to probably die. So you really want to. We consider that a bad outcome after surgery. So we want to avoid that at all costs. Okay. Now again, from the nursing standpoint, there's nothing you can do about this except watch for aspiration and make sure we do things that will help prevent aspiration and let the surgeon know, although I suspect he's going to already know it, okay, because he's going to pick it up immediately. We can see vascular injuries as a result of these procedures. And again, these are generally an intraoperative complication. We may see some present in the perioperative period, but in general, this is going to be an intraoperative problem. We can see neurologic changes. You can see a stroke or some change as a result of retraction of the carotid artery and dislodgement of either emboli or plaque that can lead to a stroke. Again, fortunately, this is a very rare occurrence, and I've not seen this in my patients. I have seen some vascular injuries. Those are generally repaired at the time of surgery, and once they're repaired, they're typically not a problem anymore. We're going to see this generally in an older patient, one that has some advanced vascular disease or carotid artery disease. When you see a patient with a neurologic change postoperatively, that's a clue that something's not right. But you're going to have to decide what that something is. And you can look at the course of the problem, you can look at the severity of it, and that can help lead us and you to a diagnosis. If you've got an immediate change, in other words, the patient is fine, then all of a sudden they're not fine, then this could, or they come out of surgery and they're not fine, and this may be an intraoperative injury, maybe something that happened during surgery. It could also be a displaced or a misplaced graft. If the graft, that piece of bone we put in there, comes forward, well, you may see a patient with dysphagia or trouble swallowing or a problem like that. If it goes the other way, back into the spinal cord, then you really have an issue. And so, we need to key in not only on what's wrong, but the time frame and how this happened. On the other hand, if you see a progressive change, the patient is fine post-operatively, but over time, they get a little worse and a little worse from the standpoint of numbness or weakness or such as that, then this could represent a hematoma, so an expanding epidural hematoma, blood clot, perhaps an abscess, although we'll generally see an abscess later in the postoperative course. It's very, very rare that we'll see one immediately. You'd almost have to spit in the wound to do that. But you want to pay attention to the course of the problem. Bottom line is that these can all be surgical emergencies. If I've got a piece of bone sitting in the spinal cord, I need to get that off. If I've got a blood clot that's expanding and the patient is going downhill, I need to evacuate that. So the timing is critical. We need, and this is why we examine patients post-operatively. It's not to make the paperwork look good. It's because no matter how rare it is, these things do happen. And the only chance we have to make it better is to pick it up quickly and fix it, go back to the operating room or do whatever we have to do. Particularly with a epidural hematoma or a graft dislodgement, you're not going to see anything on the outside. The wound's going to look fine, okay? So it's all keyed around the clinical exam. Now, the wound doesn't always look fine, okay? What we can see is a post-op wound hematoma, okay? And for neurosurgeons and the few orthopedic surgeons that do spine surgery, this is the call we hate to get, all right? But we need to get it. It's one of the most critical emergencies that we're going to encounter in the post-operative period. This is a life-threatening problem. The patient will die if we don't do something quickly, okay? So, what should you do as a nurse? Well, first of all, and most importantly, you need to know what it looks like. Now, that's easier said than done because, fortunately, we don't see a lot of these. So, years ago, if you've been in nursing for 30 years, you've probably seen some. If you're fairly new, you may have never seen this, but once you see it, you're going to know it. You will never forget what it looks like. And the patient's going to have basically a baseball on the side of their neck, and they're going to first get some trouble swallowing, then they're going to get stridors, and then they're going to turn blue and arrest, okay? And that can happen very quickly, and once you reach that point, it's a point of no return. So the timing is critical. You got to examine the wound. You got to examine the wound when they come back from surgery. You need to know what it looks like so you know if there's been any change. The other thing is you got to respond. This is not the time to go, I think there's a problem here. Let me come back in a couple hours and check and see how they're doing, okay? I would You know, I may get fussy if you call me at 2 in the morning and say, I think there's something wrong with this guy's wound, okay? But that's nothing compared to what's going to happen if I come in the next morning and the guy's dead. You know, I'm really going to be unhappy then. This will expand, and this will compress the trachea. And when that happens, all bets are off, because I'm going to tell you, the patient's going to lose their airway and they're going to die, okay? It's going to happen very fast, okay? I mean, it's not going to be a gradual thing. It'll be gradual to a point, but then once it tips over the edge, it's a done deal, okay? And, you know, again, as I said, they're usually going to complain of some difficulty swallowing first. That's a bit of a problem, because up to 50% of these patients complain of difficulty swallowing after surgery, okay? So, you know, but what's going to happen is, if it's a hematoma, this is going to progress and get worse, and the wound's going to change, and you're going to notice it, okay? So you don't have to call me for every patient that says, I'm having a little trouble swallowing, but you need to watch. And that's what, you know, that's why we put the patients in the hospital, so they can be watched. But usually after that, then they begin having trouble breathing, and that's when it becomes very, very critical. You've got to examine the wound. You've got to look at the trachea, make sure it's in the midline. We want to, if you see, you know, and don't be afraid to touch the patient and touch the wound and feel the trachea and make sure it's in the midline. Okay, but again, critical, you got to know what it looks like normally post-op. If you don't know that, if you don't take the time to examine these wounds, you won't know what it looks like when it's not normal. Okay, again, surgical emergency requiring evacuation of the hematoma. We hope in the OR. That doesn't always happen. Okay, if we're behind the curve, that patient's going to have his wound opened in the wound, and there's going to be blood everywhere. Okay, it's going to be a mess, and I know I've had to do it. I'm sure Dr. Rigsby's had to do it. It's not fun. We would much rather evacuate this hematoma in the controlled environment in the OR, not in the patient's room with the family looking over our shoulder. Okay. You can't, and you know, you call anesthesia, but they're not going to be able to intubate this patient. Once that trachea gets compressed and pushed out of the midline, it isn't going to happen. Okay, so you know, if we are lucky enough to get an endotracheal tube in, that's great. It isn't going to happen most of the time. So again, how do we avoid that? Simple. Just contact us as soon as you suspect a problem. You know, don't wait. And if you're not sure what it looks like, ask somebody. Somebody has seen one, I guarantee you. Okay? Don't be afraid. And if they have seen one, they're going to remember. Right there. Mm-hmm. It's not something you forget, is it? All right. We can also see spinal fluid leaks. Now, again, these are very uncommon. They're much more common in the lumbar spine, but we still see them in the cervical spine. And they're going to present sometimes just like a hematoma. It's going to be an expanding mass, expanding lesion. Now, the difference is, because this is spinal fluid, it's like water. If you have a drain in, as long as the drain's there, it's going to suck this stuff out. So, you know, you're not going to have a problem. You're going to take the drain out. It's got nowhere to go, and all of a sudden it's going to start expanding. But again, it's an expanding lesion, just like a hematoma, and we're going to treat it very much in the same way. It still can become an emergency. At the same time, you know, again, if you remember the pictures, we're pulling the trachea and the esophagus over to the midline. So we can see injuries to the trachea, to the esophagus, to the midline structures. It's more common if I'm having to go back in to a neck, because there's going to be scar tissue. We're going to lose the planes of dissection. And, you know, if we recognize it at the time of surgery, we can repair it, and other than being a bit of a nuisance, it's generally going to be okay. If we don't recognize it, then it can result in mediastinitis, an infection that goes down into the mediastinum, and that's a problem. We're talking about a very significant issue. 20% mortality rate if you get it treated in the first 24 hours, okay? If you don't, the mortality rate can go up to as high as 50%. So again, very, very critical. The patient's going to start looking sick. There's going to be some outward signs, and again, the surgeon is probably going to pick up on it, but it's something you always have to keep in mind. Most of the time, we're able to treat it with antibiotics, with drainage. Some will require surgical closure, but that's something that we'll look at in each individual patient. Besides anterior cervical fusions, what else do we do? Well, we do cervical corpectomies, and basically it's simply an anterior cervical fusion, but instead of removing a disc, we're removing the disc and the vertebra, whether that's 1, 2, 3, whatever. So we're actually removing the bone and the disc. We're basically dealing with the same complications post-operatively because the approach is the same. In general, the operation is doing some of the same things. But we do see some increased risk in regards to graft failures, hardware failures, and dysphagia. Obviously, if I'm working at that much in your neck as opposed to opening the whole neck up and looking at 4 or 5 vertebrae, you're going to probably have a little bit more trouble swallowing, and in fact, the literature does show that that is the case. This is one where I ended up doing a corpectomy, and what we're seeing here is actually a complication that we had to treat with a corpectomy. This patient had an uncomplicated anterior cervical fusion. This is a dialysis patient, so she's immunocompromised and diabetic and the whole 9 yards. And she develops an spinal epidural abscess. Okay, so we actually had to go in and remove vertebrae. Okay, this is a single level corpectomy. There was a disc here and there's a disc here, and we removed the vertebra in between. Okay, and then what happens is we'll take a piece of bone, I'm packing it with some bone chips here, and we'll replace that bone or the vertebra with this graft. So it's essentially a big ACF, except we're going from disc to disc rather than between 2 vertebrae. Okay. This is just a post-op picture of a corpectomy. You can see a nice fusion, everything's solid, but it's a little bit bigger operation than an anterior cervical fusion. Okay. Let's talk a little bit about posterior cervical surgery. And if you notice, we're spending a lot of time on cervical surgery because those are going to be a lot of times the more critical issues, and we'll talk about that later. But if we're doing posterior cervical surgery in general, we're doing a laminectomy, which is removing bones and decompressing. We're doing a fusion, or we're doing a combination of the two. And just to give you a frame of reference, this is a patient, heads up here. This is that, and this is the cervical spine exposed. There's the midline, that's the spinous processes, and the ligaments still intact. But this is a posterior exposure. This is a posterior exposure with some screws in, doing a fusion, and this is a combination of the two. And you can't see it very well here, but I'll show you on the next one. You can see there's no bones left. Okay, there's no bones left, and this is a decompressed spinal cord, and that's going to be important in just a minute when we talk about our potential complications. So the most common postoperative emergency is going to involve the operations that have had a laminectomy. Okay, and the reason for that is that the spinal cord is exposed. So if we get a hematoma or something expanding there, it's going to put pressure on the spinal cord. It can cause a neurologic decline. So again, it's important. You need to know what operation a patient had, because that's going to clue you in to the potential complications after that operation. Okay. Again, this can result in a progressive neurologic decline. It will most likely be a surgical emergency. And what might you see? Well, the patient might start complaining of progressive and worsening pain, numbness, weakness. If the upper cervical cord is involved, we can even see respiratory difficulties. We're going to diagnose this generally by radiographic means, MRI, something along those lines. But what's going to trigger that is a good clinical assessment by the nursing and by the physician. Okay. We can see infection do the same thing, but again, it's generally going to be in a somewhat delayed fashion. If we do a fusion and we put screws in, what we call lateral mass screws, There's an example of those back there on the Scotch table. You know, we put them in an area where they shouldn't cause problems, but nerve roots and vertebral arteries can be at risk when you're placing these screws. In addition to bleeding, if you have a vascular injury, you can see potentially a stroke-like manifestation with weakness, numbness in the case of a nerve root injury. So again, we need to watch this. Now, you know, the kicker is we can see nerve root problems in up to 10% of posterior cervical surgeries. It's usually, however, isolated to a single nerve root, usually at C5 or C6. But this isn't progressive. I mean, it's there. It's there when you come out of surgery. We will image this and make sure we don't have a misplaced screw. And this is the number reported in the literature. I don't see 10%. I doubt Dr. Rigsby sees 10%. But you know, this is a number that's reported in the literature. So, you know, again, you probably have not seen one because, again, I don't remember last time I had one. But likewise, you know, it's the same as we've seen before. If this is immediate, if they wake up with it, then it probably was an intraoperative problem. And this is going to be true of whether you're talking about the cervical spine, thoracic spine, the lumbar spine. But likewise, you know, we need to be aware of the pre-op status, because that's the other thing. You know, I hate getting a phone call at 2 in the morning that says, well, Dr. Ryan, Mr. Jones' right arm is numb. I know. That's why we did the surgery in the first place. It was numb before we started. Oh, so, you know, that's not so bad at 3 in the afternoon, but it is at 3 in the morning. Okay, but I'm pleased that they noticed. But I wish they'd have taken it another step further. And you know, I don't know if any of you guys remember Dr. Glenn Barnes. Yeah. You know, I'd first come here 20 years ago, and I got a phone call at 3 in the morning, and it said, Dr. Ryan, this so-and-so in 5:30 needs a laxative and a sleeping pill. Like, it's 3 in the morning. Okay, you don't really want to give her a laxative, and it's probably too late for a sleeping pill. And I said, wait a minute, who? Ms. Jones. I said, that's not my patient. He said, oh no sir, that's Dr. Barnes' patient, but we weren't about to call him. You know, so I learned right then, you can't be too nice at night, you know. So sometimes to make things even more complicated, we go from the front and the back, okay? And that's always a fun thing to do. So then you get to worry about problems on either side. All right, let's talk a little bit about the low back. How we doing on time? I didn't even look to see what time I started. Oh, well, I'm going to talk about finish anyway, so it doesn't matter. All right, so let's, if we're talking about the low back, the majority of what we're going to do is simple disc surgery. You know, we're going to take out a ruptured disc. This is called a laminotomy discectomy. You know, we're doing a lot of these as outpatients, and that's good, but it's also bad from the standpoint of, you know, if there's a potential, if there's something brewing, we may not pick it up because that patient's going home. So particularly the folks in the outpatient need to kind of be aware of what could potentially present as a problem and hopefully pick it up soon. But fortunately, significant complications with a lumbar discectomy are pretty rare. You know, now sometimes we'll do a decompressive laminectomy, same sort of thing. We're just removing more bone and making a bigger opening over the spine. But these are generally in somewhat older patients, so as you would expect, there's a little bit higher rate of complications. Probably the most common thing we see after surgery is a spinal fluid leak, a CSF leak. Anytime we're working near the spinal cord or the nerves, you know, we can see the spinal fluid leak. We normally see this at surgery, and we fix it. But sometimes you don't see it. Sometimes there's something that is keeping it from leaking at surgery, and then the patient's up and moving and it'll start leaking. So we do, in fact, see these not uncommonly post-op, or even if we do fix it during surgery, it starts leaking again. What you'll generally see is a postural headache. Patient's fine when they lay down, but when they stand up, their head explodes. Okay, you can have nausea and vomiting. I even see patients with chest pain. Now that's always fun. I'll call anesthesia. I need a blood patch. What's the patient got? Chest pain. You got to be kidding. No, just do a blood patch. Humor me on this one, and do a blood patch, and lo and behold, the chest pain goes away. Okay, but again, it's going to be postural. They get chest pain when they sit up. It goes away when they lay down. Okay, and which again, that's the key. It's a positional headache. Now, it's pretty easy to diagnose when the patient comes in. There's a baseball sitting on the back of their wound and clear fluid leaking out. You know absolutely what you got then. We can see vascular entries. It's generally an iliac artery or vein during surgery. For us older folks in there, remember the actor Richard Holden, that's what killed him. He had a lumbar discectomy and someone bagged the iliac vein and he bled to death during surgery. But they're not going to get out of the operating room. I mean, you have to flip them over, open their belly, repair it right then, and then try to explain how it happened. But you'll see it. You can see some delayed AV fistulas, pretty uncommon. You're going to see a hypervolemic shock. These patients are going to bleed. They're not going to bleed into the wound. They're going to bleed retroperitoneally. So you may not recognize it by a big gush of blood coming out. You may recognize it when the anesthesiologist says, we got a problem here. I can't keep this patient's blood pressure up and his heart rate's going out the roof. Okay? And of course you can see patients have lost a leg secondary to the vascular injury. You don't treat it and it's significant, they will die. So, we need to be on the lookout for any vascular compromise or vascular problems in the lower extremities. We can see in the iliacs, or what we call an Ogilvie syndrome. We see that sometimes in the bigger surgeries, fusions, and in older patients. And again, they're going to present with all the signs of something going on in their belly: distension, decreased bowel sounds, pain, noisy vomiting. It will be worsened by narcotics, and it does need to be treated. Okay, urinary retention post-op, we see that. That's most common in older men. We rarely see it in women at all, but we do see it in older men, particularly with BPH and other prostate problems, which I understand if you get old enough, we all get. I'm too young yet, but I'm sure it's coming. I'm sticking to that story. So, the bladder gets distended, and that can lead to problems. And I mean, you even see hypertension in some patients. When I finished my residency, the first case I did in private practice, I got a call that afternoon and said, the patient's belly is distended and his blood pressure is not good. And I'm thinking, my career's over. First case, I've bagged an iliac vein. I'm going to be riding on the back of an orange truck. So I rush into the hospital, and the patient looks terrible. And I'm thinking to myself, nothing went wrong during surgery. And I poke on his belly, and there's this huge balloon sitting above his pelvis. And I'm like, so put a Foley in it. And, 5 minutes later, he was perfectly normal, 1,800 cc's of urine's out. And so, ever since that, I always check, because I never forget that sick feeling in my stomach thinking my career was over on the first day. We do bigger operations. These are lumbar fusions, where we're putting screws and rods and fusing the back. These are typically longer procedures. They'll typically have a little bit higher blood loss, or at least the potential for blood loss, and for some intraoperative hypotension if you're doing a really big one, if you're doing an osteotomy or something where you're having to remove whole vertebrae and things like that. We do most of them through the posterior approach. There are some done anteriorly. Again, we're placing screws into the pedicles of the vertebra or into the sacrum. We a lot of times we'll put a graft into where the disc was in the interspace. But again, just like all lumbar surgery, the vascular structures can be at risk. The risk of infection is higher than most operations because there's hardware, because it's longer, surgery because there's more tissue, trauma. We also can see the same things we've seen before. We can see spinal fluid leak. We can see anemia due to blood loss. Again, here's our epidural hematoma. We can see that as well. But in most cases, you know, there's a difference if you get an epidural hematoma over the lumbar region, which is peripheral nerves, then there's a good chance that we're going to get that out. The patient's going to be okay, although it's not 100%. The big difference then if you have an epidural hematoma in the cervical spine that's pressing on the spinal cord. Okay? But you're also going to have, this is going to probably be a little more indolent course. So you always have to keep that in the back of your mind. This is an unusual one, but I actually have seen this. There is a risk of blindness after lumbar fusions. We believe it's the postulation in the literature is that it's due to the length of surgery and increased retinal pressure and with decreased retinal perfusion. There's a high risk in diabetics. So if for some reason you have a patient that's had a lumbar fusion and they come back to the room and they say they can't see, they may not be crazy. Okay, this may be real, so don't blow them off as a nutcase. Or don't say, well, that has nothing to do with your back, because it actually can. This is just an example of a lumbar fusion, just to show you these are screws that we placed into the pedicle. You can see it here. It's found the dura with the nerves is decompressed here. Just this is a picture of got to put a graft into the inner space. I've got an instrument that's a rasp that goes down in the inner space and scrape it and prepare the inner space. But what I want you to notice, and what I'm really showing this far, here's the nerve root. You see that nerve right there? And that nerve root has to be kind of moved out of the way. It's got to get retracted. So, you know, what we can see post-op, we can see patients that will have some numbness or some neuropathic burning type pain in that nerve root. We try very hard to be gentle with the nerve root to try to avoid the injuries, but we can see that, and that's something, again, that we need to recognize because there are some medications and things we can use to try to make that better. Just a blown up bad picture of that's not very focused, but you can see that's a pretty nasty thing that I'm scraping back and forth by that nerve root. And this is just a picture with the rods, at least one side with the rods in place. This is a single level fusion, and you can see the graft that I'm placing into this space here, and right there, that little thing right there is the nerve. Okay. Just another example. You can actually see the nerves through you see those lines, those are the nerves that are under the dura, and the graft's in place, and there's those screws. And this is what they look like post-op. Here's a graft in place here. We have some little lines on the graft so we can see where it is. So if that graft moves, if it comes back here, I'm going to see that and I'll know that something's wrong. Okay? But you can't see it very well otherwise. Thoracic spine, again, just as the neck and the low back, we go from the front, we go from the back. Essentially, all of the things that we've dealt with in the cervical and the lumbar spines can present in the thoracic spine. The thoracic spine does have some unique issues, however. You can see a pneumothorax. If we're working on thoracic spine, the pleura is just under the ribs, and so we can inadvertently cause a pneumothorax, which of course can lead to even a tension pneumothorax, where we compress the heart and the vascular structures, and we can see a patient can crash, go into shock, and they have cardiovascular collapse. Usually around T6, T7, there's an artery that we call the artery of Damkowitz, and that supplies blood. Very simply, supplies blood to the spinal cord. That artery can be at risk during surgery. We have to be very careful of that, because if we injure that artery, we can render the patient paraplegic. And even without banging the spinal cord, if we have a problem with that artery, they can lose blood supply and have a stroke of the spinal cord. You can see it delayed. You can see thrombosis, but in general, it's going to happen right off the bat. Not all of our post-operative complications are due to the surgery. We can certainly see medical problems. We see cardiac problems in patients afterwards. They get chest pain, they get arm pain, which is fine, except when they had a cervical fusion for left arm pain. And then they come back to the floor and they're complaining of left arm pain. Only we fixed the cervical problem. Now they're having an MI. And so, you know, again, they're no different from the other patient. If they're having left arm pain and they feel fine, and they got a little tingling in their hand, that's one thing. If they're having left arm pain and their jaw hurts and they're short of breath and they're diaphoretic, okay, don't say, oh, well, he had surgery on that arm. He's going to, you know, his nerves irritated. I'd rather have a negative cardiac workup than a positive autopsy. Obviously, we're all very familiar with this because this is, it gets shoved down our throats every day, and rightfully so. Deep vein thrombosis and pulmonary embolus, particularly in larger operations or operations that immobilize the patient, more prevalent in orthopedic procedures, but we do see it in spine surgery. Again, the key is prevention, but if you've got it, you need to recognize it, and it's pretty simple. You know, positive Holman sign, which is you push the foot back and it causes calf pain, calf swelling, tenderness, upper thigh, doesn't matter. But always keep that in the back of your mind when you've got a patient that says, my leg hurts, my leg's swollen. You know, it's easy to get a venous Doppler and know that there either is or is not a deep vein thrombosis. Occurs in about 3% of spine surgeries. Fortunately, pulmonary embolus is less, but the highest risk is if we do an anterior or a combined thoracolumbar surgery. Okay, again, bigger surgeries, higher risk. How about this? I mean, withdrawal or overdose on medications. Okay, a lot of these patients that we're treating have chronic pain. They're living at the pain management doctor's office and they're taking 27 medications, 500 milligrams of morphine. You know, they've got a patch on every square inch of their body, and it's not Nicoderm. But you know, so we bring them in, and for some reason we stop all those medicines and give them 2 Lortab, and then we wonder why they're jittery and acting crazy post-op. They're withdrawing, you know. So whether you think it's a good idea or not, or whether you think the patient's a drug addict or something's wrong, you don't want to stop these medicines in the immediate post-op period. Let the pain management guys do that afterwards. So it's important. And also, I mean, I can't tell you how many times I've had a little old lady stay in hospital 3 days, letting that 1 dose of morphine wear off, and me trying to explain to the family that she's really okay. We've just over-medicated her because she's very sensitive to drugs. And for 2 days, they think you're lying, they think you're crazy. And then the patient wakes up, but you know, by that point, it's never a good situation. So we want to be careful. And if you notice, there's, you know, right here I'm telling you give them plenty of medicines, and here I'm telling you to be careful. Know your patient, okay? It's not that hard to do. We've got nice forms now that tell us every patient the medicine's on. I know that because you called me all night and said I signed the form, okay? All right, so the bottom line, recognize these problems, know what they look like, and act early. Early is better than late. There's no substitute for a good clinical exam. Listen to the patient, even if you think they're a nutcase, okay? Listen to it, because they're going to generally tell you what's wrong, you know, or at least give you the information so you can look in the right direction. And you need to understand, be prepared. Understand the potential complications of any surgery, and be prepared to act when you see that complication occurring. Again, hopefully early rather than late. So the course, remember the course and severity of the changes can be critical in diagnosing the problem and treating it appropriately. Immediate changes generally going to represent an intraoperative problem. Progressive changes are generally going to be something like a vascular problem, an epidural hematoma, or again, much less likely an abscess. And that's it. Yes.
Yeah.
The blindness after fusion, first of all, it's rare, but it can be transient, but generally that patient is left with at least some permanent visual problems.